Hi everyone, I'm Rikia. I'm from Baylor College of Medicine. I'm going to talk to you about Langerhans cell histiocytosis. LCH is a inflammatory myeloid neoplasia with highly variable clinical manifestation ranging from self-resolving focal lesion to aggressive and fatal multi-system disease involving the skin, bone, lung, and central nervous system, and as well as hematopoietic system. It can occur at any age, but is most common in children and has an incidence approximately 5 cases per million children, similar to the frequency of Hodgkin's lymphoma or AML in children. Although there is variable clinical representation, they look same under the microscope. Pathologic cell identifiers are Langerhans and CD1A, as shown here by IHC and flow cytometry. In spite, clinical outcomes have steadily improved over the past decade. Standard of care chemotherapy fails to cure more than 50% of children with high-risk disease. And the majority of patients have long-term consequences, including a devastating neurodegenerative syndrome that can arise years after a patient is presumed to be cured. So we need better therapeutic options for LCH. The problem is there is no ideal system that model system where you can study LCH. That's why the pathogenesis is unknown. But we were able to build a biobank by enrolling almost 500 patients who has LCH and used that biorepository to study the oncogenic mutation associated with the disease. Here is the list of oncogenic mutation presented in this figure. But there is a group of patients where we were unable to find any mutation so far. Additionally, one important observation that we see is there is universal ERK activation in all LCH patients, irrespective of mutation status. But there is no significant correlation that we were able to find so far. So we also found that the activated ERK provides an anti-apoptotic advantage and helps the pathologic cell persist in the lesion by impairing migration. Since all the mutations found in MAPK pathway and there is a universal ERK activation in LCH lesion, this suggested the use of MAPK inhibitor as a potential drug. But it has its own pitfalls and limitations. So far what we know is MAPK activation helps in this lesion formation by activating the anti-apoptotic advantage. But when we look in the stroma, we see there is a lot of immune infiltrate present around these cells. When we did the immunophenotyping, we found that these immune infiltrate is majorly contributed by T lymphocytes, which is shown here by the red box and the green bars. Not only that, we also see that the CD4 helper cells are overtaking the cytotoxic cells in the lesion. But both these populations express exhaustion markers and they are functionally impaired. So when we found this, we designed a strategy where we can combine MAPK inhibitor along with immunotherapy and look if it gives an additive effect for designing a better therapeutic strategy for LCH. For that, we used a mouse model which represents LCH-like disease, and we treated the mice with anti-PD-1 and MEK inhibitor over 14 days. And at the end of the study, we looked at clinical measures at multiple levels as well as the immune measures. Here is a quick sneak peek where it shows a lot of promise because we see a significant reduction in the disease burden in lung and liver, and this is an ongoing study. ASH Scholar Award really helped me develop my intellectual freedom, increase my collaboration, and also helped me in getting recognition in the hematology field. I was also able to participate in the TRTH program, which helped me develop skills to bag Career Development Award from Department of Defense, and that kind of helped me establish my independent research lab and my current lab interested in looking at the co-inhibitory receptors listed here and the molecular interaction between them for tumor persistence. With that, I would like to thank all of you for your attention. And this is a picture of our group, so I'm thankful to every individual. Thanks.